Buenas tardes. Sadly enough, that is pretty much my Spanish. My Portuguese, bom dia. It's nice to see all of you. My name is Marshall Summar. We have, I think, a very interesting lunchtime session on urea cycle disorders and some new treatments around a disease we don't think about very much, Arginase 1. I will go through some things around sort of the current standard of care in urea cycle, introduce some concepts around Arginase 1. Then we have Dr. Carolina Fischinger, who everyone should know. She's past president of the society. She is one of the leading biochemical geneticists in Latin America, and I think is known pretty much across the world. And then we have Dr. Mattias RUDEBECK, who is representing from Imedicines, and we'll be talking about some of the new enzymatic things like that. So, without that, let's get going. Everybody got their lunch? Relax, enjoy. If you have any questions, we'll probably put those towards the end, okay? All right. This symposium has been organized by Imedicines Pharma. Pegzilarginase is currently only approved in the EU and Great Britain. First talk, my side will be optimizing treatment. Second, on arginase in LATAM. The third is treatment with enzymatic replacement. So I'll start. First off, it's good to see all of you. I have so many familiar faces here. I love this meeting. It's one of my, I think it actually might be my favorite meeting, but don't tell the SIMD that. The speaker reports no conflicts, so I don't have any financial, and I'm not being paid to give this talk. So the different types of urea cycle disorders, I think most of us are familiar with those. We have, OTC, which is probably the most common we see, and then kind of the core enzymes, CPS, ASS, ASL, and then citrin deficiency, which has a particular predominance in Asia. And then we have sort of our two orphan diseases, one of which is an acetylglutamate synthase, of which we don't have too many patients. And then the other one that we don't really think about much is Arginase 1 deficiency, which presents differently from our regular patients and can present with some, a lot of different clinical symptoms as well too. So we're going to do what we call in the US rare squared. So that's when you take a rare disease and it's a rarer version. All right, so what are some of the common themes to treatment in the United States? So I will speak about what we do back home, but I think these are fairly common in general. Obviously, the top priority is to protect the brain. So when we're treating a patient in acute phase or chronic management, our first goal is to protect the brain. How do we do that? We try to physically remove the arginine by some form of dialysis or filtration. We will heavily impact nutrition, so however many nutritionists we have, they are one of your absolute keys to management of these patients. And then we will use pharmacology to remove excess nitrogen so that nutritionally we can give more, but also give that patient a safety margin from their day-to-day life. Sort of the rationales: avoid catabolism. When these patients start breaking down their own protein, that releases a lot of nitrogen. That can happen in the newborn period. It can happen during infections, which is a peak time when the patients get sick. Even if they break a bone, there's a lot of catabolism going on there. We want to maximize our dietary nitrogen. In other words, essential amino acids. We want to try to give these patients enough nitrogen to grow. That's why we use a lot of the medications we do, because we can get a diet that's closer to normal, which is good for brain development, growth, and everything else. The medications we use currently are for the purpose of removing extra nitrogen so that we can give more nitrogen. And also when the patient is building up excess nitrogen, to try to remove that as well. So we'll use a lot of different methods to do that. I once said, I would use as many different nitrogen scavengers as I could safely with the patient, because that means then from a nutritional standpoint, we can keep them closer to normal. There's kind of three phases of treatment. There's always that acute presentation when the patient first presents. One of the things you have to remember, if you look at long-term neurodevelopment and everything else, this is actually your most critical period. If the patient takes severe brain damage here, then you're going to have that for the rest of their treatment. Then you have chronic and long-term. Chronic can be what medications and diet you use. Long-term can be such things as, do you transplant the patient's liver? Are there other, methodologies there, some of the new things around gene therapies and others that are going on. So we try to restrict extra protein, but at the same time make sure the patient receives sufficient essential amino acids. Nutritional supplements, we use amino acids that are made in the urea cycle depending on where the defect is. So if you have a high defect in either OTC, CPS, we'll add citrulline in because that actually is readily absorbed. We'll go on and actually pull a little nitrogen in from aspartate and then go on around the pathway. If we have an ASS or ASL deficiency, then we'll usually add arginine, the amino acid past, because then we want to spin the pathway back to citrulline, which will pull some nitrogen in and also kind of generate urea, things like that. The other treatments that provide alternate routes for nitrogen removal. We'll talk about that in a little bit. Of course, different forms of dialysis when the patients are in acute phase. Most of the severe newborn patients in the United States these days are going for transplantation. Does it fix everything? Absolutely not. In the OTC patients, you still have to supply citrulline to them. In the patients with ASS and ASL, you usually correct the hyperammonemia, but you still have many issues around nitric oxide metabolism and other things. So when you transplant a liver, you're not fixing them. You've changed one disease out for another. It's just that they're more stable and you can have a little more safety and some neuroprotection. For our scavenging medications, this goes back a long way, probably back to the 1970s, when they realized that phenylacetate will combine with glutamine to make phenacetylglutamine, which can be excreted in the urine. You have to be careful with phenylacetate because it is a toxic molecule at high levels, but if you give it within kind of good ranges, you can pull a lot of glutamine. The advantage to pulling glutamine is it is partially responsible for the neurotoxicity in urea cycle disorders, so not only are you scavenging excess nitrogen, you're also removing one of the primary toxins. Benzoate is another one we use. People like benzoate. First off, it's very cheap. You can buy it in the carload. Any of you having any type of processed food are probably getting yourselves a nice dose of benzoate right now. So you can use that. It binds with glycine, which the body will replace, and then is excreted as hippurate, which the kidney will excrete very readily. So think of these as nitrogen trappers. So they trap the nitrogen into a form that is excreted in the kidney. One of the things that means is when you're managing an acute patient, you need to be very careful to make sure you preserve kidney function and kidney health. Because without that, there's no place for these drug products to go. So then you can't use them. So a lot of the patients, remember, will come in with very low blood pressures, very extreme, so you want to make sure that you preserve their kidney function. So one of the newer drugs we've got is glycerol phenylbutyrate. It's new and it's not. It's been around since the 1990s, but in humans only for the last couple of years. It is a pro drug. We're all familiar with phenylbutyrate, which is the pro-drug for phenylacetate by beta oxidation step. Glycerol phenylbutyrate is simply 3 phenylbutyrates stuck onto a glycerol molecule. And the advantage is it's the same mechanism of action. It's phenylacetate at the end of the day combining with glutamine. But it takes a long time to break those phenylbutyrates off the glycerol, get them into circulation, then convert them to phenylacetate. So it creates a slow release form. The thing I like best about it, have any of you ever tasted phenylacetate or phenylbutyrate besides me? Y'all are a lot smarter than I am. Nasty tasting stuff. For adults, the dose of phenylbutyrate can be up to 40 capsules a day because it comes in kind of a half-gram capsule. The nice thing about the glycerol phenylbutyrate, like the glycerol implies, it's a liquid. So it's pretty tasteless. It's kind of like a shot glass size, so I told my teenage patients, oh, you're going to get to drink out of a shot glass, and they felt very grown up doing that. So they thought they were drinking alcohol. They're not. But basically, it's a prodrug for phenylacetate. Here's some of the experience we've had with this. If you use just straight up phenylbutyrate, it clears fairly quickly, which means you either have to dose it more often or you're going to have periods where you're uncovered. You can dose the glycerol phenylbutyrate less often, and the area under the curve is longer because the drug breaks down slowly. So it's just simply a matter of the kinetics of the drug rather than anything else. It's not any different in its final mechanism of action. Let's talk a little bit about ARG1, because I didn't pay a lot of attention to this for most of my career because the incidence is probably about 1 in a million. We did some surveys of newborn screening over about 8 to 10 million births in the United States and looking to see, and it turns out it's probably pretty close to about 1 in a million. Now, once you start paying attention to a disease, you start to find more of them, but it's still one of the rarer urea cycle disorders. I don't know whether N-acetyl-glutamate synthase or arginase is rare, but you can make an argument for both of them. It's that last step in the pathway. When you take the arginine, you strip out the urea, and then you regenerate ornithine, which can then push the cycle back around. So there's two things. One, it's that last removal of the urea, which is excreted in the kidney, but also it regenerates the ornithine that allows the pathway to continue to spin. So you have to regenerate the intermediates in the pathway. Prevalence, like I said, some places they say 1 in 57,000. I think it's probably closer to maybe 1 in a million, but as we're learning more, that number is going to change because a lot of that's kind of guesswork at best. Incidence in newborn screening is where I get the 1 in a million. It's an autosomal recessive like everything else except OTC in the urea cycle, and there's a lot of genetic variation in this condition. So unlike kind of their classic newborn male OTC with no activity, these patients have a lot more variation, 2 copies of the gene. Some are mild, some are more severe, and that leads to a lot of clinical variation. How's it toxic? Well, a couple of ways. One is in your classic urea cycle fashion where things build up and ammonia builds up, but also arginine in high doses is neurotoxic. So you get sodium, potassium, ATPase pump problems, decrease in energy metabolism, increased oxidative stress, which leads to neuronal cell death and some other cell death. It's not very good for the liver either. Remember, arginine is transported by dibasic amino acid transport, so it can also compete at the transport level with other dibasic amino acids. So there's a number of ways this can cause a lot of problems for the patient. You end up with demyelination, which is where we get some of the neurologic findings. So you get neuromotor, neurocognitive, neuroexcitatory changes, all of kind of the above. Now, interesting, where we're used to seeing our severe urea cycle patients right in the newborn period, these patients can take over a year to present, and then can present in a whole variable age range, but a lot of them don't present until 6 months. Why does that make them harder to detect? Well, we always pay close attention in the newborn period. A newborn gets really sick, we're like, oh, okay, what's going on? When you're 6 months, maybe you're not growing as fast or your development's not quite as on track. We tend to say, well, maybe this kid's just having a little bit of delay, things like that. So this is one of the urea cycle disorders where diagnosis can be delayed just because the symptoms are not as obvious or a little slower to develop. Some of the things the classic arginase patients will present with are spasticity in their lower limbs, which then will go on and progress. So they can lose the ability to walk if they gain that. Some of them won't gain the ability to walk. Obviously, this is from neuromotor cell death and disruption from that standpoint. If it's left untreated, they will eventually decline, and there's very little data on mortality, but it looks like these patients do die younger than their contemporaries without the disease. So that's kind of the classic description of arginase deficiency. Now here's the interesting thing. Some of them will present, not many, but some of them will present like classic urea cycle disorder. We had a patient present, looked exactly like your classic OTC, hyperammonemia, liver in bad shape. Then we got the sequence and the amino acids back, and it was arginase deficiency, and that patient went on to transplant. That's not unique. There are other patients with arginase deficiency that will present with classic. I have a feeling that there's a second thing going on there that's probably making them behave that way, but you'll kind of get some of both. They'll still also have the neuromotor changes as well too. But some commonalities between other urea cycle and arginase include seizures, global developmental delay, which we see in almost all of our patients, and hepatic impairment. You know, remember our arginosuccinic acid lyase patients, will develop long-term liver disease. They will get cirrhosis, things like that. You can also see that in patients with arginase deficiency. But they will typically appear normal at birth and then for the first period. So you've got to be very careful there. So that's kind of that. And then mortality data is really hard to get. Some of the patients die early, maybe the ones that are more severe, but I think we've got a long way to go. One of the things I will ask is Juan Francisco Cabello will have a little survey that we're doing just amongst ourselves to kind of see how these patients do. He's got a QR code for it. He'll come by and chase you. He's got to chase all 200 of you down. That's going to be fun. But we'd love to get your experience for that, because what we're finding is there's just not a lot of good consolidated data on arginase deficiency yet. And that's because it's so rare and it's so scattered. All right, diagnosis is biochemical, elevations in plasma arginine, so it is detectable by newborn screening, although remember, the patients in the immediate newborn period, the mother has been biofiltering the arginine, so you're going to miss a lot of patients there, so you're going to have a lot of false negatives. So don't assume if the patient had a normal newborn screen that it's not arginase deficiency, but typically when the levels are above 300 micromolar, that's kind of a good range to think that that's what's going on. The enzyme activity is on red blood cells, and then it's also available in a lot of the metabolic panels for DNA sequencing. Newborn screening, we talked about that. And then the genetics or ARG1 mutation analysis. All right. So, that is actually one important thing. How many neurologists do we have in the group? Quick show of hands. Yeah, these patients also get missed because people think they've got some form of hereditary spastic paraplegia, and so they don't often include arginase in some of those genetic sequencing panels. You kind of want to make sure that they actually do. So just be aware of that and carry that one forward. So does it work to reduce arginase? And it's hard to get arginine down low. It will help with the motor skills. So if you can get the arginine kind of below 200 micromolar, that's been our target by and large. It varies from center to center. It's hard to do. You've got to reduce the protein generally. You can use some of the scavengers to help with that. Remember, most of your arginine you make yourselves, but it's also available in a lot of things that come into the diet. So you got to be careful. The other thing to remember is a lot of the nutritional IV formulas have a fair amount of arginine in. So if you're using TPN on a patient from the nutritionist, check the arginine content in there. Sometimes it can be quite high. So can the glutamine levels, as you already know. Liver transplantation, usually for those patients that are having severe hyperammonemia. Otherwise, a lot of the arginase is actually in red blood cells. So the distribution is kind of pretty much around the body, so to speak. And then you can really decrease some of the clinical manifestations. Like I said, help out with the neurodegeneration by getting the arginine level down. It's just hard to do. We try to keep it below 200 micromolar. Why do we pick that number? That seemed to be the best we could do. So I'd love to say that that's the magic level at which all symptoms go away. It's not. It's just that is actually kind of an achievable target. That seems to help with neurologic progression and hyperammonemic crisis. For our treatments, we use low protein, medical foods, essential amino acid mixtures, make sure they don't have arginine in them, some of them do. Nitrogen scavengers, benzoate phenylbutyrate, glycerol phenylbutyrate, we'll kind of throw a bunch of things at it there to decrease nitrogen flow through the urea cycle, and just try to manage the complications. So what's the limit of our standard care? Basically, 97% of the patients out there who are being looked at are above the normal dietary range for arginine. So we can't get it down to normal. You know, normal's typically kind of below 100 micromolar, somewhere in there, and that's not a magic number, but it's kind of more what the normal number is. And most of your arginine is from de novo synthesis. So, you know, the liver is going to make it. Actually, the gut makes a lot of arginine. So you're really fighting against a lot of systems providing arginine. And you're still getting elevated levels of the guanidino compounds, even when you're doing your best treatment levels. So we have treatment that is not really satisfactory at this point. And at that, I'm going to turn it over to Carolina, who's going to talk about a good patient. Thank you very much.
Oops. So thank you, Marshall. Thank you for the invitation to be here, to be a part from this symposium and to the Congress organization. I was asked to present in English because my portuñol no es muy bueno. Entonces, é protectivo para ustedes hablar in English. So I will present some of my experience to treat patients with deficiency of Arginase 1. This is my disclosure. I will start with the first case. The date of birth of this case was 2012. She's now 11, referred to genetic evaluation at 6 months of age because the laboratory diagnosed of Arginase deficiency 1 due to neonatal screening. In Brazil, the private neonatal screening covered the analysis of complete amino acids, and the patient was diagnosed by a private neonatal screening. No specific problems during the gestational history, and she's a healthy and non-consanguineous parent. She's the second child of these non-consanguineous parents. And the neonatal screening showed in amino acid chromatography the elevated arginine in the spot was for a long time. That was confirmed by APLC analysis with a very high amount of arginine. The reference value you can see here. And in the second samples, we could also see that the very high levels of arginine, the reference value was until 150, and the patient present 709. Here is the girl when she was 3 years of age. As Dr. Marshall told, no problems before 12 months of age. She had head control with 2 months, sitting independently with 5 months, and could walk independently with 14 months. And the speech was before 2 years. But at age 4, she started to have a rapid neurological regression. Started with tiptoes, spastic diplegia, development regression, and that was in the time that she started to present epilepsy. First seizure, and then more and more that was under control until now. Currently, she is a wheelchair bound and with worsened speech and have adapted school curriculum. The complementary investigation for this case showed that ammonia levels is normal during the basal analysis without specific clinical decompensation. She has also a high uric acid that is also a biochemical marker that could help of the diagnosis. And the liver enzyme, it's a little bit high also before the treatment of anti-seizure drugs, anticonvulsivant drugs. She has she's a heterozygote for 2 missense mutation, and the brain image showed the enlarged ventricular space and metabolic change with increase in lipid and lactate and glutamine levels. That it's very nice specific marker for urea cycle disorders. And in 2019, the electroencephalogram showed generalized and multifocal paroxysm in cortical dysfunction and worsening in the multifocal epileptic encephalopathy comparing to the electroencephalogram done before. Here we can see the clinical manifestation of this case. You can run the video, please, but I can do also here, okay? Weight and height, it's okay. Head circumference in the limit, but normal. Motor function, no independent walking. walks with hand support, can stand, flat valgus, as you can see here, shortening of Achilles tendon, and a high deep tendon reflex showing the spastic paraplegia, and also associated with Babinski signs. The speech was so little bit dysarthric and slow speech. At that time, orotic acid was still a little bit high, ammonia levels normal, but during the metabolic crisis, after a virus infection, the ammonia was in the limit of 200, that is high for this case, and the patient was a little bit somnolence manifestation and worse of movement disorders. Here is our amino acid profile. Glutamine was normal. The patient was treated for argininemia. I will explain in the next slides. But all other control amino acids was not so high. Arginine was also in the limit of normality at that time. I'm not a neurologist, I'm a medical geneticist, but for a medical geneticist, if we see this electroencephalogram, we can see that it's not normal. Many spikes. I know that it's a lot of neurologists in the audience, but it's obviously not normal, you can see here. And as you can see, the severity of the seizure manifestation, she is now using 5 drugs related to control the seizures and the polypoints and spike waves complex that is very difficult to control in this case. She started the treatment when she was 6 months of age with protein restriction, recommended natural protein since she was 8 months of age. But I need to tell you that the adherence from the family was not so good. She was not eating natural protein like meat and eggs and milk, but other protein without specific control. And also we added the L-carnitine and glycerol phenylbutyrate that the patient also used. I think this is very important to show you the clinical manifestation, the evolution and the progression of this severe disease. In this case, I will show you here the videos when she was 3 years of age, 5 years. 9.
Não tem medo não, você consegue.
And 11, she could not walk. She's very infantile. She is not now going to the school. And this represents that despite the early diagnosis, the treatment, the restriction diet, and use of nitrogen, scavenge, the progression of the disease is very clear in this case. So moving to the next slide. As Dr. Marshall told before, the estimated of the prevalence of arginase deficiency is a little bit inconsistent, but it is a ultra-rare disorder because if we see some results from a systematic review, we saw that the frequency is 1.4 cases per million people. It's here we can see the frequency from some countries in Latin America that we have the estimated cases based on population, and the prevalence in Argentina, Brazil, Chile, Colombia, and Mexico are a little bit the same, a little bit more maybe in Colombia. And we know that the poor disease awareness is under-responding on newborn screening mean, and patients may be undiagnosed and the burden of the illness higher than previous thought. And as Dr. Marshall mentioned, we included in our evaluation of spastic patient in our hospital the analysis of arginine. It's included in our flow chart, the biochemical analysis. The other nice work published from the group of Brazil in 2012, from the group of Sara Kubitschek in Brasilia, showed the results of 16 cases with arginase deficiency. Here we can see the age of diagnosis of this case is a little bit late that we could expect it, and the gait acquisition was normal, and the first neurologic symptoms were related of seizures of lower limb spasticity. That is the most important signs that we can see. And in my view, you need to include the amino acid analysis and in spasticity patients for all, and also for patients that start with seizures before a normal development. The cognitive skills for most of them is from severe to moderate or mild mental retardation, and it's an open access article. You can show more results, and here the blood arginine concentration for most of cases it's high, for some not so high, and the correlation also with microcephaly, that it's also symptoms related to arginase deficiency. This is very nice also systematic review from 291 arginase deficiency patients, showing that the proportion of the patient receiving various of treatment intervention, and most of them, they are submitted to diet restriction, combined to the nitrogen scavengers and dialysis or liver transplantation in most of them, but the outcomes of the patient is intellectual disability, motor function disabilities, spasticity, alteration in behavior, need for hospitalization, and also death for some case. In a nice study from the Mexico group, we saw these results of a retrospective observational study of a historical cohort, the patient with inborn errors of metabolism, correlated with the patient that was submitted to newborn screening and the patient that was not submitted from newborn screening, showing the high mortality rate from the patient that was not submitted to, that was not screened. And from this cohort, we can see the frequency of argininemia deficiency, 2% in all metabolic disorders that could be evaluated in this article. And the mortality of unscreened group is higher, despite the bad response for the treatment. It's important to treat the patient because the patients that are not treated, they have higher mortality. And the frequency of these all cases was 2.5 comparing to other inborn errors of metabolism. Now I move to the next case. They are a very nice case. They are a sibling. The first sibling started with vomiting, sometimes with lethargy. She has insomnia and drowsy during the day, and also never accepted to eat meat. That was one of the symptoms that refused to eat protein, natural protein, as a meat. That was typical from this case. And the arginase deficiency was confirmed by Dr. Chamoles in Argentina when she was 5 years of age. And the motor symptoms at that day was gait disorders. And with 6 years of age, she couldn't not longer to walk. Also, she present with seizures, was treated with phenobarbital and phenytoin, now only phenobarbital, and she is now seizures-free for 20 years, and she was not attended, not attended this, she attended the school until 14 and not more. So the second sibling was diagnosed when she was 1 month of age, because the first sibling was affected, and the mother was advised to breastfeeding, but the control of volume for control the protein intake, and at 3 months she started with specific metabolic formula, UCD1, and sodium benzoate, and she was submitted to a more diet control comparing to the first, to the sister. The psychomotor evaluation showing that she started to walk with 15 months, seizures, none, hospitalization only 1 time in the life, and the motor symptoms of this case started when she was 12 months, 12 years, totally different comparing to the sister, and the difficulty to walk was noted in this case with starting of tiptoes. The amino acid profile was done. The diagnostic at that time was only biochemical, but was confirmed now the mutation of these 2 siblings that affect a canonical site. One of mutation is pathogenic, and the second mutation is one VUS. So this second case I will present now. She have a normal ammonia levels, little bit high orotic acid, hepatic function totally normal, but despite the diet restriction, she has sometimes B12 deficiency. It's very important to measure all parameters that is possible in this case, because the dietary management can restrict from other elementary and important vitamins. And here we can see the glutamine high and arginine under 200, that is the goal of the treatment for this case. So the first sibling is totally wheelchair, and the second sibling is here. I can show you the spastic paraplegia. She is economist now, have normal development, normal cognitive development, but she is using a lot of medication to improve the quality of life and to control the arginine levels. In this case, we saw the spastic gait, shortening of Achilles tendon, deep tendon reflex increased, muscle strength is totally normal, speech is normal, she don't have any ataxia or dystonia. In conclusion, the current management, as we present here, it is insufficient now to maintain the very good metabolic control. We can try to put the patient in a metabolic control, but as we can see, most of them could not be in the goal of the under 200. That is the guidance levels. And it's necessary to supplementary arginine-free essential amino acids to improve the growth and to improve the development. And nitrogen scarvents is also frequently used to reduce the risk and to protect the brain in this case, and to reduce the risk of hyperammonemia when the patient has some infection complication. But as you can see, comparing these last 2 siblings, they are a little bit different clinical manifestation. I don't believe that is not only related to the early diagnosis, but maybe related to another important things that we need to point here. The same arginase, ARG1 mutation, and subjects that are submitted to the same diet pattern during the childhood involved with different neurological impairments. Other factors can influence the severity of the disease, including upregulation of mitochondrial, second isoenzyme arginase in other tissue, maybe arginase 2, and of course, an individual susceptibility to brain damage caused by some metabolites of arginine and nitric oxide and guanidine compounds in some cases that have urea cycle disorders. So I conclude here. Here is Casa dos Raros. It's a new project in south of Brazil that are dedicated to evaluate and the multidisciplinary team to care patients with rare or ultra-rare disorders. And I thank you here. It was a pleasure to share with you my cases of arginase deficiency. I will invite now my colleague.
Thank you very much for two very excellent presentations. So I will switch focus a little bit, but continue on the presentations from Marshall and Carolina. So I will talk about pegsilogenase, which is a novel enzyme treatment for arginase 1 deficiency, and I will present the clinical data from the phase 3 study, which is called the PEACE study. And these are my disclosures. So I'm an employee and shareholder of Imedica, which is the company that owns the rights to this product that we will be talking about in this presentation. And this product that we are talking about is, as I said, pegsilogenase. It's an E. coli-derived recombinant human arginase 1 enzyme. And it has been engineered to deliver enhanced degradation of arginine. And that has been done in two different ways. So one is the manganese replacement with cobalt, but also the pegylation of the enzyme. So that's compared with the native enzyme, you will have higher catalytic activity and also longer half-life of this enzyme. And as you can see here in the figure over here, that in these patients, as we heard, when they have a deficient arginase 1 enzyme will have accumulation of arginine within their bodies. Arginine will accumulate from the urea cycle, but that can bidirectionally be transported to other tissues and fluids in the body, so also into the plasma, as you heard, and we will have elevated arginine levels in the plasma. Pegsilogenase will actually work within the plasma. So it will be administered to the patients, and then it will break down arginine in the plasma to urea, and that can be excreted, and then to ornithine as well. And the ornithine can then go back to the urea cycle, as Marshall mentioned, and restart the urea cycle. So if you provide an enzyme treatment to a patient that works in the plasma, that also means that when you draw blood from this patient, you will have the enzyme active within the blood that you have collected. So in the clinical trial that I will be presenting the data from now, we actually used specific blood collection tubes that contain the arginase inhibitor Nornoa. So when you draw the blood from the patients, the arginase inhibitor will inhibit the pegsilogenase in the blood, and you will get the correct values of arginine in the patients. And the clinical development program consisted of 3 studies. So it started with a phase 1-2 study that included 16 patients. It was a single ascending dose study that wanted to find the optimal dose in managing the arginine levels in these patients. Those patients could then continue into an open label long-term study that continued with dosing for 4 years. And the phase 3 study that we will talk about here included 32 patients. So in total, 48 patients were included in the clinical development program for pegsilogenase. And this is an overview of the study design of this phase 3 study. So it was a randomized, double-blind, placebo-controlled international study, and we looked at the efficacy and safety of weekly administration of pegsilogenase. And as you can see from the inclusion criteria, so the patients had to have a documented arginase 1 deficiency diagnosis, they had to be 2 years or older, they had to have elevated plasma arginine levels above 250 micromolars, and they had to have a baseline deficit in at least one of the clinical response assessments that we were measuring in the study, and I will go through them shortly as well. I mentioned 32 patients. These were randomized 2-to-1 to either pegcellariginase, so 21 patients, or placebo, 11 patients. Those were randomized into a 24-week-long double-blind period where they received either than 0.1 milligram per kilogram of pegcellariginase weekly, and that was administered intravenously in the double-blind period, or volume-matched placebo. After the double-blind 24 weeks, all patients had the option to go into the open-label extension phase of the study, and then all patients received open-label pegcellariginase active treatment, and then they could also start receiving the doses subcutaneously as well. During the study, they titrated the dose to make sure that the arginine levels were managed, so they could titrate the dose up to 0.2 milligram per kilogram as the maximum, or down to 0.05 milligram per kilograms. The long-term extension phase was up to 150 weeks. For the efficacy outcome, so the primary endpoint was the plasma arginine reduction from baseline. In the secondary endpoints, we looked at clinical outcomes. So the 2-minute walk test was one of the key secondary endpoints, and that's really the distance that the patient walks over 2 minutes. We also used gross motor function scales, so the gross motor function measure, GMFM scale, which is validated for patients with cerebral palsy that has similar spasticity and mobility issues as in arginase 1 deficiency. This scale has 5 different dimensions. So in this study, we used 2 of those dimensions that were more relevant for the population. It was GMFM-E, as you can see, was one of the key secondary endpoints, and that is a dimension with tasks that look at walking, running, and jumping tasks. As other secondary, we have the GMFM-D dimension, and that is tasks related to standing. We also looked at the proportion of patients that would be able to be below 200 micromolars in arginine levels, and also the proportion of patients that would be able to reach normal limits of arginine levels. We looked at plasma ornithine levels and also guanidino compounds, these toxic metabolites of arginine as well. Here is the demographics and baseline characteristics of the patients. So it was a randomized study, so the randomization was successful. As you can see, the groups were comparable. You can see that the pegcellariginase group was slightly younger than the placebo group, but both groups had highly elevated plasma arginine levels of 365 versus 472 micromolars at baseline, even though they were on standard of care treatment. So these were already on a diet treatment when they entered the study, and when then also continued on their standard of care treatment. Moving into the results of the study, so this is the primary endpoint, looking at the decrease in plasma arginine from baseline. And as you can see, the graph in blue, which is the active treated patients, they had a rapid reduction in their arginine levels. And really, somewhat before, but around week 8, they were actually within the normal range, as you can see. For the placebo patients, they were maintained at the plasma arginine levels that they had at baseline. But after the 24 weeks, when they were then put on active treatment, you can see that they had the same trajectory as the patients in the double-blind period that had the active treatment. And in this slide here, we also show data for 48 weeks of treatment for the longest. But the study is actually closed now, and we have data up to 152 weeks. So we can see that the plasma control is actually sustained up to 150 weeks of treatment. During the double-blind period, it was a statistically significant difference between the 2 groups. And you can see here also that more than 90% of the patients at week 24 of the double-blind period were actually within the normal range. And those 90% also includes one patient that was actually withdraw their consent early in the study, so before week 8 due to personal reasons, and the statistical plan included that value as a last observation carry forward. So that value is included in that calculations as well. We also looked at plasma ornithine, as I said. That was also a statistically significant difference, so an increase in ornithine in the patients that were treated. We looked at the guanidino compounds, so 4 different guanidino compounds relevant for arginase 1 deficiency, and they were also statistically significantly decreased in the patients that were treated. If we look at the clinical outcomes, so I mentioned the 2-minute walk test. You can see here still the patients on active treatment are in blue. They had an increase of 7.3 meters in the 2-minute walk test, and the placebo patients 2.7. For the gross motor function, so the dimension E, you can see that the total score of E is 72 points, and the patients on pegsilogenase had an increase of 4.2 points, and the placebo patients a decrease of 7.4 points. None of these were statistically significant different, but I will also show the predefined thresholds for clinical meaningful change in these scales as well. For the gross motor function measured D, so that is for standing tasks, you had an increase of 2.7 points out of a total of 39 in the scale, and a 0.4 in the placebo group. As I mentioned, the study is now closed, and it was closed at the same time for all patients, so not all patients went up to 152 or 50 weeks. That was the plan. The median exposure, excluding the 24 weeks of double-blind exposure, was 94 weeks, so the range was 62 to 152 weeks. And as you can see here, for those patients that were on the active treatment during the double-blind period, these are week 24 data, is what I showed also in the previous slide. They continued to improve with longer-term treatment, both in all of these different scales. If we look at those patients that were on placebo in the double-blind period, they also had then improvements when they were put on long-term active treatment as well. And I mentioned also the clinical meaningful change. So in the slide here, you can see that there are lines, and those are the predefined literature-based thresholds for a minimum clinically important difference. And those are based on the severity of the disease in the patient at baseline. But in the end of the study, you can see that all patients, or both groups actually were above all of those thresholds for clinical relevance of the results as well. The safety profile was manageable. As you can see, the majority of the adverse events were mild to moderate in severity. We didn't have any deaths in the study and no adverse events that led to discontinuation. We had a predefined adverse events of special interest due to this being a enzyme treatment, so you could expect, based on experience with other enzyme treatments, that these patients could have severe hypersensitivity reactions. But as you can see from the data here, we didn't see any severe hypersensitivity reactions, so those that were reported were infrequent, and they were also mild to moderate in severity. And with this data, as Marshall mentioned in the beginning, it has been approved for marketing in the European Union and Great Britain, and the indication is for the treatment of arginase 1 deficiency in patients 2 years and older. And the recommended initial dose is the same as was in the clinical trial, so 0.1 milligram per kilogram per week. And they can be administered either intravenously or subcutaneously, and you would use the same dose and the same formulation in these patients as well. In Europe, we actually also have an approved label where, if it's deemed appropriate, that if they receive subcutaneous injection, the physician can provide training to the patient or to the caregiver, and then they can actually provide the treatment at home, either caregiver administered or patient self-administering the treatment as well. So in summary, so this phase 3 clinical trial with data up to 176 weeks in total showed normalization of plasma arginine levels in patients with arginase 1 deficiency, and also with clinical meaningful improvements in clinical outcomes, functional mobility outcomes, with this manageable safety profile. And this data is also supported then with the phase 2 study, where they have been treated up to 262 weeks, which demonstrates the same data in the open label setting as well. We will be outside here as well if you have further questions, but we have a QR code, so if you want to contact us, you can just scan the QR code and you will get the email address, and you can send any medical information questions or anything that you need as well. Thank you.
So how much time do we have left for questions? Just 5 minutes? So, yeah, 5.5, yeah, that's true. So if anyone has a couple of very quick questions, and you know, so we have somebody back there. Yeah.
Hi, nice presentation. Carolina talked about a peak on spectroscopy at the lipid zone. We have seen it, for example, in some argininosuccinic aciduria patients. Do you think it could represent guanidinic compounds in spectroscopy on MRI? And do you think this could be a diagnostic tool in these cases?
Do you mean that we can measure the guanidine compounds in spectroscopy? That is the question?
Do you think the peak on the lipid zone reflect the presence of guanidinic compounds? And do you think it could be some diagnostic tool for these patients? Maybe because it's most frequent than spastic paraplegia patient had a MRI than amino acid studies.
So I think that could help, but we found these compounds, it's more rational to think in creatine deficiency transportation comparing to arginase deficiency. But I don't know if you usually measure this.
I think it's one of those things that we need a lot more data on before we figure out the diagnostic ability of it. Creatine would probably make the most sense. The thing to remember, though, is creatine's under a lot of other different controls. It's under some hormonal control. It's under, you know, there's a developmental pathway and things like that. So I would say before I would say, yes, use it as a diagnostic, I would say right now it needs to be studied.
Okay, thanks.
Sure.
Sí, era mi pregunta para el doctor Marshall. Y la cuantificación de aminoácidos sigue siendo el gold estándar. Sin embargo, los países que estamos en vías de desarrollo, como por ejemplo Perú, no tenemos cómo hacer la cuantificación de aminoácidos. Entonces, ¿qué diferencias habría entre hacer la recolección en un papel de filtro versus una cuantificación en plasma de los aminoácidos?
Okay, thanks.
She is from Peru, and she's asking that in Peru it's difficult to quantify the amino acid profile, and she wants they can do in paper, and chromatography. What is the difference?
Okay. That's actually a great question. So what she's asking is, can you use paper chromatography to measure amino acids? Because not everybody's got either an ion exchange chromatography system, you know, like the Waters or one of those, or has a tandem mass to do these things from, because they're just not there. Paper chromatography is problematic because when you dot the paper with the blood, the enzymes in the blood are still active. So you actually, depending on how long the blood sits on the paper, can actually affect those. We actually played some with this because the same question, if you pre-treat the paper with EDTA to basically take away some of the molecules that you need, you can actually stabilize it, and then the paper is pretty reliable. It's just not going to be quite as quantitative. But for the purposes of seeing that something is wrong, big peak's a big peak. That's the nice thing. You know, and it's a lot of arginine or it's a lot of glutamine, so you can get that. There are some new HPLC methods, which HPLC is usually more widely available. We published one of them, I think, last year or year before, but there's some good methods out there that are very simple. It's good to see you.
Gracias.
And I think we're down to about 1:20. I'll hang around afterwards. I know Carolina will as well too, and I know Mattias will because he has nowhere else to go. So if you have any questions, well, I think there's probably a talk in here right after this, so we'll wait outside that so they can get moving with the next. But thank you all very much for your attention and attendance today. And thank you to our sponsors for this meeting. I hope you didn't just show up for the food, but if you did, I hope it was good. Nice job.
Good.